Question 1. During general anesthesia induction, a 55-year-old male patient with a history of mild asthma is undergoing a laparoscopic cholecystectomy. The anesthesiologist administers propofol and succinylcholine for muscle relaxation. Shortly after administration, the patient experiences a sudden increase in heart rate, muscle rigidity, and generalized hypertension. What is the most likely cause of these symptoms and how should managed? A. Acute allergic reaction to propofol. B. Malignant hypothermia due to succinylcholine. C. Anaphylaxis caused by muscle relaxants. D. Cardiac arrhythmia induced by propofol. Answer: B. Malignant hypothermia due to succinylcholine. Explanation: the most likely cause of these symptoms is malignant hypothermia MMA, a rare but life-threatening condition that can be triggered by volatile anesthetics and depolarizing muscle relaxants such as succinylcholine. MH is characterized by muscle rigidity, tachycardia, hypercapnia, hypertension, and hypothermia. The condition results from a genetic predisposition leading to uncontrolled calcium release from the sarcoplasmic reticulum in skeletal muscles. Immediate management involves discontinuing the triggering agents, in this case succinylcholine, administering dantrolene, the antidote for MH, and implementing supportive measures like cooling and correct metabolic abnormalities. Question 2. A 72-year-old patient undergoing hip replacement surgery presents with a history of chronic obstructive pulmonary disease, COPD. The anesthesiologist plans to administer epidural anesthesia for pain management. Given the patient's medical history, which of the following is the most critical consideration in choosing this anesthetic technique? A. Epidural anesthesia is contraindicated in patients with COPD due to respiratory depression risks. B. The dose of local anesthetic should be reduced to avoid excessive sympathetic blockade, which could worsen respiratory function. C. Epidural anesthesia should be avoided as it increases the risk of blood clots in patients with COPD. D. General anesthesia is preferred as it allows for better control of respiratory parameters in COPD patients. Answer: B. The dose of local anesthetic should be reduced to avoid excessive sympathetic blockade, which could worsen respiratory function. Explanation: in COPD patients, regional anesthesia such as epidural is generally considered safe, but special caution must be taken to avoid excessive sympathetic blockade. Overly strong sympathetic blockade can lead to vasodilation, hypotension, and further respiratory compromise by decreasing the ability of the body to compensate for low oxygen levels. Therefore, a low dose of local anesthetics should be used to avoid these complications. It's essential to monitor the patient's respiratory function closely during the procedure. Option A is incorrect because epidural anesthesia is not contraindicated in COPD, and option D overlooks the advantages of regional anesthesia in terms of postoperative pain control and minimizing respiratory complications. Question 3. Mr. Jones, a 65-year-old patient with a history of diabetes and hypertension, is scheduled for elective surgery. Preoperative assessment reveals that his fasting blood glucose level is 106 mg/L. His blood pressure is controlled with medication. Considering the patient's comorbidities and the surgical procedure, what is the most appropriate anesthetic plan? A. Proceed with general anesthesia and use long-acting opioid analgesics for pain management. B. Anesthetic management should include tight glucose control, either with insulin or other measures during the perioperative period. C. Epidural anesthesia should be avoided in diabetic patients due to an increased risk of infection and bleeding. D. Defer the surgery until the patient's blood glucose is within the normal range. Answer: B. Anesthetic management should include tight glucose control, either with insulin or other measures during the perioperative period. Explanation: in patients with diabetes, maintaining tight glucose control during the perioperative period is crucial to minimize complications such as infection, poor wound healing, and increased risk of cardiovascular events. Elevated blood glucose levels can compromise the immune response and increase the risk of surgical site infections. The use of short-acting insulin or an appropriate insulin regimen should be implemented to control blood glucose levels alongside vigilant monitoring. Option A is incorrect because long-acting opioids may cause significant postoperative respiratory depression, especially in diabetic patients. Option C is also incorrect as epidural anesthesia can be safely used in diabetic patients provided there are no contraindications such as severe infection or coagulopathy. Question 4. A 30-year-old female undergoing elective surgery is scheduled for general anesthesia She is 6 weeks pregnant, and while her pregnancy is uncomplicated, she is concerned about potential effects of anesthesia on the fetus. Which of the following general anesthetic agents is considered the safest for use during pregnancy? A. Isoflurane. B. Nitrous oxide. C. Sevoflurane. D. Desflurane. Answer: C. Sevoflurane. Explanation: Sevoflurane is considered one of the safest inhalational anesthetics for use during pregnancy due to its relatively low maternal and fetal toxicity profile. Although all anesthetic agents have some degree of potential risk, sevoflurane has minimal uterine effects and is less likely to cause fetal harm compared to other agents. Nitrous oxide B is not recommended in the first trimester due to potential effects on fetal development, and desflurane D and isoflurane A may be associated with higher risk of maternal hypotension, especially in the first and second trimesters. Question 5. A 70-year-old male undergoing surgery for aortic valve replacement is on anticoagulant therapy with warfarin. His INR is 2.8 prior to surgery. What is the best course of action to manage this patient's anticoagulation therapy before the surgery? A. Continue warfarin and proceed with surgery as INR is within the therapeutic range. B. Hold warfarin for 5 days and perform surgery with the INR in the normal range. C. Administer vitamin K immediately to reverse the effects of warfarin before surgery. D. Use low molecular weight heparin until the INR normalizes and proceed with surgery. Answer: B. Hold warfarin for 5 days and perform surgery with the INR in the normal range. Explanation: For patients undergoing surgery with an elevated INR due to warfarin therapy, it is generally recommended to withhold warfarin for 5 days prior to surgery. This allows time for the INR to return to a therapeutic range. If the INR remains elevated close to the surgical date, additional reversal agents like vitamin K or frozen plasma may be used to correct the INR. Option A is not correct because the INR of 2.8 is above the normal range for surgery. Option C is not necessary unless the INR is significantly elevated. Option D could be considered for bridging therapy but is not the first-line approach in a patient whose INR can be normalized by simply withholding warfarin. Question 6. A 60-year-old patient with known liver cirrhosis is undergoing a laparotomy for gastric cancer. The anesthesiologist is concerned about the patient's hepatic function and decides to modify the anesthetic approach. Which of the following would be the most appropriate modification in this patient's anesthesia management? A. Use volatile anesthetics exclusively, avoiding intravenous agents. B. Choose intravenous anesthetics with minimal hepatic metabolism, such as propofol. C. Reduce the dose of muscle relaxants, as patients with liver cirrhosis are more sensitive to these drugs. D. Avoid using opioids altogether due to the potential for liver toxicity. Answer: B. Choose intravenous anesthetics with minimal hepatic metabolism, such as propofol. Explanation: Patients with liver cirrhosis have impaired hepatic function, which affects the metabolism and clearance of anesthetic agents, especially those metabolized by the liver. Propofol is metabolized extrahepatically, making it a better choice than other intravenous anesthetics in these patients. Volatile anesthetics can be used, but they should be administered cautiously, and muscle relaxants C should indeed be used with caution in these patients. Opioids D should not be avoided altogether, but used with careful dosing and monitoring, as they are metabolized in the liver, but appropriate doses can still be used safely with close monitoring. Question 7. Mr. Green, a 45-year-old obese male undergoing bariatric surgery, has a BR of 40 kilograms and he has obstructive sleep apnea, OSA, and hypertension. Which of the following anesthetic techniques would be most appropriate for managing his airway during surgery? A. General anesthesia with endotracheal intubation and deep sedation. B. General anesthesia with laryngeal mask airway LMA to reduce risk of airway collapse. C. Regional anesthesia with sedation, avoiding general anesthesia altogether. D. Awake fiber optic intubation for controlled airway management. Answer: D. Awake fiber optic intubation for a controlled airway management. Explanation: For patients with obesity and obstructive sleep apnea, OSA, there is an increased risk of difficult airway management due to airway obstruction during anesthesia. Awake fiber optic intubation D allows for optimal control of the airway, as it enables the patient to be conscious enough to assist in airway maintenance while ensuring that airway patency is preserved. Intubation: General anesthesia with deep sedation may, or laryngeal mask airway B. Can be risky, as OSA patients are prone to airway collapse or difficulty with mask ventilation. Regional anesthesia with sedation, C. Could be an option for certain cases, but does not provide as secure an airway management approach as awake fiber optic intubation. Question 8. A 74-year-old male with a history of COPD, diabetes, and mild heart failure is scheduled for an elective cholecystectomy. The patient's lung function is compromised as evidenced by reduced FEV of 60%. The anesthesiologist is concerned about intraoperative respiratory complications. Which of the following is the most appropriate anesthesia management strategy for this patient? A. Administer high concentration of oxygen throughout the procedure. B. Use short-acting opioid as the primary analgesic and limit the use of volatile anesthetics. C. Perform regional anesthetic technique and avoid general anesthesia. D. Ensure adequate postoperative pain management to prevent respiratory depression. Answer: D. Ensure adequate postoperative pain management to prevent respiratory depression. Explanation: patients with COPD are at high risk for postoperative respiratory complications, such as hypoventilation, pneumonia, and atelectasis. Ensuring adequate postoperative pain management, D, is critical to prevent respiratory depression, which could worsen the patient's already compromised respiratory function. Using high concentration oxygen, A, can lead to oxygen toxicity and carbon dioxide retention in COPD patients. Short-acting opioids, B, should be used cautiously as they may exacerbate respiratory depression, but they are not a primary concern in intraoperative anesthetic management. Regional anesthesia, C, can be considered, but it is not always possible or the most effective approach for certain surgeries like cholecystectomy. Question 9. Mr. Harris, a 65-year-old male with a history of hypertension and coronary artery disease, is scheduled for coronary artery bypass grafting CAG during induction as blood pressure drops significantly despite adequate fluid resuscitation. The anesthesia team is considering the use of a pharmacologic agent to maintain hemodynamic stability. Which of the following agents is most appropriate for managing hypotension in this patient? A. Epinephrine, B. Norepinephrine, C. Phenylephrine, D. Dobutamine. Answer: B. Norepinephrine. Explanation: norepinephrine, B, is the most appropriate agent for managing intraoperative hypotension in a patient with coronary artery disease CAD. Norepinephrine is a potent vasopressor that increases systemic vascular resistance without significantly increasing heart rate, which is important in CAD patients to avoid increased myocardial oxygen demand. Epinephrine A is typically avoided in CAD patients as it can increase heart rate and myocardial oxygen demand, which may precipitate arrhythmias or ischemia. Phenylephrine C is a pure alpha agonist that can increase systemic vascular resistance but can also cause reflex bradycardia, which may be problematic in this context. Dobutamine D is a positive inotropic agent that increases heart rate and cardiac output, but more commonly used in patients with heart failure, not in the context of hypotension alone. Question 10. A 56-year-old female with an ER of 42 and a history of obstructive sleep apnea (OSA) is scheduled for an elective hysterectomy under general anesthesia. Given her obesity and OSA, the anesthesia provider plans for a careful perioperative management strategy. Which of the following actions is most likely to reduce her risk of postoperative respiratory complications? A. Administer opioids in high doses to ensure adequate pain relief. B. Place the patient in the Trendelenburg position during surgery to improve oxygenation. C. Use a multimodal analgesia approach, including regional anesthesia. D. Provide a high-flow nasal cannula postoperatively for oxygen support. Answer: C. Use a multimodal analgesia approach, including regional anesthesia. Explanation: obesity and OSA increase the risk of postoperative respiratory complications such as hypoventilation, atelectasis, and obstructive events. A multimodal analgesia approach, C, including regional anesthesia. E. Epidural or nerve blocks is the most effective strategy to reduce opioid requirements, thereby minimizing respiratory depression. Opioids in high doses should be avoided in obese patients with OSA due to their risk of exacerbating respiratory depression. The Trendelenburg position, B, can worsen ventilation perfusion mismatch and should be avoided. High-flow nasal cannula, D, is useful for oxygen support but does not address the underlying issue of pain management and opioid sparing. Question 11. A 50-year-old female with a history of hypothyroidism, diabetes, and obesity is undergoing an elective laparoscopic cholecystectomy. During the preoperative assessment, The anesthesiologist notes that the patient has an increased risk of postoperative hypothermia due to obesity and impaired thermoregulation. Which of the following strategies is most appropriate to minimize this risk during the procedure? A. Use a warming blanket during surgery and limit the use of cold intravenous fluids. B. Avoid regional anesthesia and opt for general anesthesia to ensure proper temperature regulation. C. Administer a high dose of opioids preoperatively to reduce shivering and enhance heat production. D. Keep the operating room temperature below 18 deg to promote heat retention in the patient. Answer: A. Use a warming blanket during surgery and limit the use of cold intravenous fluids. Explanation: obese patients, especially those with hypothyroidism, may be at risk for postoperative hypothermia due to impaired thermoregulation. Using a warming blanket A is a safe and effective strategy to prevent hypothermia by providing external warmth during the procedure. Cold intravenous fluids B should be avoided because they further lower core body temperature. Regional anesthesia B does not inherently affect thermoregulation in the way that general anesthesia does, so it is not a necessary modification for hypothermia management. High doses of opioids C are not recommended as they may contribute to respiratory depression and do not help with thermoregulation. The operating room temperature should be kept at a normal range, usually 2 deg, not excessively cold D. Question 12. A 40-year-old male with no significant medical history is scheduled for a knee arthroscopy. During the preoperative evaluation, the anesthesiologist notes that the patient is on a regimen of selective serotonin reuptake inhibitors (SRS) for generalized anxiety disorder. Which of the following anesthesia considerations is most relevant in this patient? A. Estrus may increase the requirement for local anesthetics during regional blocks. B. Esters have no impact on anesthetic agents and do not require any special considerations. C. Esters can increase the risk of serotonin syndrome when combined with certain anesthetic agents. D. Esters should be discontinued prior to surgery to prevent interactions with anesthetic agents. Answer: C. Esters can increase the risk of serotonin syndrome when combined with certain anesthetic agents. Explanation: Esters increase serotonin levels in the central nervous system and can increase the risk of serotonin syndrome when combined with certain anesthetic agents, such as those that affect serotonin transmission, e.g. mepridine. Symptoms of serotonin syndrome include hypothermia, altered mental status, autonomic instability, and neuromuscular abnormalities. Esters do not increase the requirement for local anesthetics, and there is no general guideline to discontinue them prior to surgery, D, unless a specific drug interaction is suspected. Although esters can interact with anesthetic agents, there is no need to stop their use unless a potential interaction is identified. The idea that esters have no impact on anesthetic agents, B, is incorrect because careful consideration must be given to drug interactions. Question 13. Mr. Stevens, a 72-year-old male with a history of type 2 diabetes, hypertension, and mild heart failure, is scheduled for aortic valve replacement. The anesthesiologist is concerned about the patient's increased risk for intraoperative hemodynamic instability. Which of the following strategies is most appropriate to manage this patient's blood pressure during surgery? A. Maintain high mean arterial pressure map to ensure coronary perfusion as the patient has history of heart failure. B. Administer aggressive diuretics preoperatively to ensure optimal fluid status during surgery. C. Use beta blockers to decrease heart rate and reduce myocardial oxygen demand during the procedure. D. Administer large volumes of crystalloid fluids during induction to prevent hypotension. Answer: A. Maintain a high mean arterial pressure map to ensure coronary perfusion as the patient has a history of heart failure. Explanation: maintaining a high mean arterial pressure map A is crucial for patients with a history of heart failure, especially during major cardiovascular surgery like aortic valve replacement. This ensures adequate coronary perfusion and minimizes the risk of myocardial ischemia during surgery. Diuretics, B, are not typically used in the preoperative period unless the patient is in volume overload, as they may lead to hypovolemia and worsen hypotension during surgery. Beta blockers, C, are often used in patients with coronary artery disease to reduce myocardial oxygen demand, but in this context, maintaining adequate perfusion is more critical. Administering large volumes of crystalloid fluids, D, is not typically the best approach for managing blood pressure in patients with heart failure, as it could lead to fluid overload and worsen hemodynamic instability. Question 14. A 55-year-old woman undergoing a mastectomy under general anesthesia has a history of obesity, hypertension, and asthma during the perioperative period. The anesthesia team notes difficulty with ventilation and suspect airway obstruction. Which of the following is the most likely cause of her airway obstruction? A. Laryngospasm due to the use of volatile anesthetic agents. B. Obesity-related restricted airway due to excessive soft tissue in the neck and pharynx. C. Endotracheal tube displacement due to excessive airway manipulation. D. Acute exacerbation of asthma triggered by anesthetic agents. Answer B. Obesity-related restricted airway due to excessive soft tissue in the neck and pharynx. Explanation. Obesity B can lead to airway obstruction during anesthesia due to excess soft tissue in the neck and pharyngeal regions. This can result in restricted airflow, especially when the patient is in a supine position during surgery. Laryngospasm can occur, but is more commonly associated with a light plane of anesthesia or a manipulation. Endotracheal tube displacement C is possible, but less likely if the tube is properly secured and placed, and it is not the most likely cause of airway obstruction in this patient. Asthma D could contribute to respiratory complications, but airway obstruction due to anatomical factors in obesity is the more likely cause in this scenario. Question 15. A 60-year-old male with a history of chronic kidney disease (CKD) is undergoing elective hip replacement surgery under general anesthesia. The anesthesiologist is concerned about the impact of the patient's renal function on drug metabolism and excretion. Which of the following agents is most appropriate for induction in this patient? A. Etomidate. B. Ketamine. C. Propofol. D. Thiopental. Answer A. Etomidate. Explanation. Etomidate A is the most appropriate agent for induction in patients with chronic kidney disease (CKD) because it has minimal renal metabolism and is not dependent on renal function for elimination. Ketamine B can be used in certain circumstances but is more likely to increase blood pressure and heart rate, which could complicate the management of CKD patients with hypertension. Propofol C is commonly used for induction but requires caution in patients with CKD, as it is metabolized by the liver and may be associated with a risk of hypotension in patients with poor renal function. Thiopental D is not ideal in CKD patients due to its long half-life and reliance on renal excretion. Question 16. A 68-year-old male with a history of chronic obstructive pulmonary disease (COPD) and coronary artery disease (CAD) is scheduled for a left hip replacement. The anesthesia team is concerned about his potential for postoperative respiratory complications. Which of the following strategies is most appropriate to reduce the risk of postoperative respiratory complications in this patient? A. Preoperative optimization with bronchodilators and corticosteroids to improve lung function. B. Intubation with a double-lumen endotracheal tube for lung isolation and ventilation. C. Use of high-dose opioids for pain management to minimize respiratory drive. D. Postoperative mechanical ventilation for a prolonged period to prevent atelectasis. Answer A. Preoperative optimization with bronchodilators and corticosteroids to improve lung function. Explanation. Preoperative optimization A with bronchodilators and corticosteroids is a well-established strategy in patients with COPD to reduce the risk of postoperative respiratory complications such as atelectasis and pneumonia. These medications help open airways and reduce inflammation, improving lung function before surgery. Double endotracheal tubes B are typically used for lung isolation in thoracic surgeries, not in hip replacement procedures. High-dose opioids C should be used cautiously in patients with COPD because they can suppress respiratory drive and worsen hypoventilation. Postoperative mechanical ventilation D is not necessary unless the patient is unable to maintain adequate ventilation on their own and it is associated with increased risks. So, ventilator-associated pneumonia. Question 17. A 45-year-old female is undergoing a thyroidectomy under general anesthesia. During the surgery, the anesthesiologist notices that the patient develops signs of hypocalcemia, including tingling in her hands and around her mouth. Which of the following is the most likely cause of this patient's hypocalcemia? A. Parathyroid gland injury during surgery. B. Administration of excessive Romainoids during the procedure. C. Hypothyroidism exacerbated by anesthesia agents. D. Hyperventilation causing respiratory alkalosis. Answer A. Parathyroid gland injury during surgery. Explanation. The most likely cause of hypocalcemia in a thyroidectomy patient is parathyroid gland injury, which can occur during thyroid surgery. The parathyroid glands are located near the thyroid and can be inadvertently damaged, leading to decreased production of parathyroid hormone (PH) and hypocalcemia. Symptoms of hypocalcemia include tingling, muscle cramps, and excess romanoids B are unlikely to cause hypocalcemia unless they contain large amounts of phosphate, which could bind calcium, but this is not a common cause during thyroidectomy. Hypothyroidism C would not cause hypocalcemia in the acute postoperative period, and hyperventilation D causes respiratory alkalosis, which leads to a decrease in ionized calcium levels, but is not the primary cause in this case. Question 18. A 72-year-old male with a history of ischemic heart disease and a recent myocardial infarction is undergoing a colon resection. The anesthesiologist is concerned about the management of his intraoperative myocardial oxygen demand. Which of the following is the most appropriate approach to reduce myocardial oxygen consumption during surgery? A. Administration of nitroglycerin to reduce preload and afterload. B. Use of high-dose opioids to induce deep sedation and reduce heart rate. C. Use of a volatile anesthetic agent like sevoflurane to induce myocardial protection. D. Administration of beta blockers to prevent tachycardia and reduce myocardial oxygen demand. Answer: D. Administration of beta blockers to prevent tachycardia and reduce myocardial oxygen demand. Explanation: the most appropriate approach D in managing myocardial oxygen demand is to use beta blockers, which reduce heart rate, decrease myocardial contractility, and lower blood pressure, all of which reduce myocardial oxygen consumption. Beta blockers are commonly used in patients with ischemic heart disease or a myocardial infarction. Nitroglycerin can reduce preload and afterload, but is more commonly used to treat acute myocardial ischemia rather than prevent myocardial oxygen demand during surgery. High-dose opioids may provide sedation but are not as effective as beta blockers in managing oxygen demand. Volatile anesthetics C, such as sevoflurane, can provide some myocardial protection but are less reliable, reducing myocardial oxygen consumption compared to beta blockers. Question 19. A 32-year-old male is scheduled for a laparoscopic appendectomy under general anesthesia. The patient has a history of difficult intubation due to a small mouth and limited neck mobility. Which of the following is the most appropriate airway management strategy for this patient? A. Use of a videolaryngoscope for intubation. B. Use of a fiber optic bronchoscope for awake intubation. C. Use of a laryngeal mask airway (LMA) for airway management. D. Premedication with large doses of benzodiazepines to ensure relaxation. Answer: A. Use of a videolaryngoscope for intubation. Explanation: in a patient with a history of difficult intubation, the use of a videolaryngoscope is an ideal strategy. It allows for a clear view of the vocal cords even in patients with limited mouth opening and neck mobility. A fiber optic bronchoscope B is a good option for awake intubation but is more invasive and typically used in situations where the air is anticipated to be very challenging. A laryngeal mask airway (LMA) C is useful for airway maintenance but not for intubation and may not provide adequate protection in patients with difficult airways. Premedication with large doses of benzodiazepines D could impair the patient's ability to cooperate during airway management, increasing the risk of complications. Question 20. A 55-year-old male with a history of asthma is undergoing a lower abdominal surgery under general anesthesia. The anesthesiologist notes that the patient has an increased risk of bronchospasm during the procedure. Which of the following is the most appropriate preoperative management to minimize the risk of bronchospasm? A. Administer a preoperative dose of inhaled corticosteroids and bronchodilators. B. Preoperative use of systemic corticosteroids to prevent inflammation during surgery. C. Administering intravenous fluids to reduce airway irritation during anesthesia induction. D. Preoperative administration of an opioid analgesic to decrease bronchoconstriction. Answer: A. Administer preoperative dose of inhaled corticosteroids and bronchodilators. Explanation: administering a preoperative dose of inhaled corticosteroids and bronchodilators is the most appropriate strategy for minimizing the risk of bronchospasm in asthmatic patients. These medications help to reduce airway inflammation and open the airways, improving lung function during the perioperative period. Systemic corticosteroids B are used in severe cases but are not as effective as inhaled medications for preventing bronchospasm. Romanoids C do not prevent bronchospasm and could contribute to fluid overload, especially in patients with respiratory conditions. Opioid analgesics, D, can actually increase the risk of bronchospasm by depressing respiratory drive and triggering histamine release. Question 21. A 55-year-old male undergoing abdominal surgery develops hypotension and bradycardia after the induction of general anesthesia. He has no prior history of cardiac disease. His blood pressure is 85/55 mmHg and his heart rate is 45 bpm. Which of the following is the most appropriate next step in managing his condition? A. Administer atropine to treat the bradycardia. B. Administer phenylephrine to raise the blood pressure. C. Administer epinephrine to treat both hypotension and bradycardia. D. Initiate fluid resuscitation to treat the hypotension. Answer: A. Administer atropine to treat the bradycardia. Explanation: in this case, the patient is experiencing bradycardia and hypotension after induction, which is commonly seen in vagally mediated bradycardia due to anesthesia. The first-line treatment is to administer atropine. A, to increase heart rate. Phenylephrine. B, is a vasopressor used to increase blood pressure but does not address the underlying bradycardia. Epinephrine. C, is not the first choice as it can increase both heart rate and blood pressure, but it is more commonly used in cases of more severe hypotension or cardiac arrest. Fluid resuscitation. D, can be helpful in hypotension, but addressing the bradycardia is more critical in this case. Question 22. A 64-year-old male with a history of chronic kidney disease (CKD) is undergoing major surgery under general anesthesia. He is also receiving high-dose intravenous fluids intraoperatively. What is the most appropriate strategy for monitoring and preventing renal complications during the perioperative period? A. Maintain strict monitoring of urine output and serum creatinine levels. B. Use diuretics to prevent fluid overload. C. Avoid using any nephrotoxic medications, including contrast agents and certain antibiotics. D. Administer high doses of vitamin C to prevent oxidative stress. Answer: A. Maintain strict monitoring of urine output and serum creatinine levels. Explanation: the most appropriate strategy for monitoring and preventing renal complications is to closely monitor urine output and serum creatinine levels. Monitoring urine output is essential to assess kidney function during surgery and guide fluid management. Diuretics, B, are not routinely used unless there is clear evidence of fluid overload. Their use can worsen kidney function. Avoiding nephrotoxic medications, C, is important, but it is not as specific to the perioperative period as monitoring urine output and serum creatinine. Vitamin C, D is not a proven strategy for preventing renal complications and is not routinely used in this context. Question 23. A 28-year-old female is undergoing a cesarean section under spinal anesthesia. After the administration of the spinal block, the patient develops hypotension, nausea, and bradycardia. What is the most appropriate intervention to treat these symptoms? A. Administer ephedrine to treat hypotension. B. Increase the dose of the spinal anesthetic to relieve nausea. C. Administer atropine to treat the bradycardia. D. Tilt the patient's head down to treat hypotension. Answer: A. Administer ephedrine to treat hypotension. Explanation: the most appropriate intervention for hypotension after spinal anesthesia A is to administer ephedrine. Ephedrine increases both heart rate and blood pressure, which helps to counteract the effects of the sympathetic blockade caused by the spinal anesthetic. Increasing the dose of the spinal anesthetic B is not appropriate, as the symptoms are due to the effects of the existing dose, not an inadequate one. Atropine C may be used for bradycardia if it is symptomatic, but ephedrine is more appropriate for treating both hypotension and bradycardia. In this case, tilting the head down D is not an effective treatment for hypotension and is not a standard intervention. Question 24. A 45-year-old female with a history of asthma is undergoing laparoscopic surgery under general anesthesia. The anesthesiologist is concerned about the potential for bronchospasm during the procedure. Which of the following is the most appropriate preoperative management to minimize the risk of bronchospasm? A. Administer inhaled bronchodilators and corticosteroids before surgery. B. Administer systemic corticosteroids to prevent inflammation. C. Avoid the use of volatile anesthetic agents during the procedure. D. Administer a general anesthetic that causes deep sedation. Answer: A. Administer inhaled bronchodilators and corticosteroids before surgery. Explanation: the most appropriate preoperative management for minimizing the risk of bronchospasm in a patient with asthma is the use of inhaled bronchodilators and corticosteroids. These medications open the airways and reduce inflammation, helping to minimize the risk of bronchospasm during surgery. Systemic corticosteroids can be used in cases, but inhaled treatments are generally more effective for asthma patients. Avoiding volatile anesthetics is not necessary unless there is a specific concern, as these agents can be safely used in asthma patients with appropriate management. Deep sedation is not a preferred strategy and could worsen airway control. Question 25. A 72-year-old male undergoing surgery under general anesthesia develops a sudden increase in end-tidal co-echo and a sudden rise in peak airway pressure. The anesthesiologist suspects an issue with ventilation. Which of the following is the most likely cause of these symptoms? A. Pneumothorax. B. Airway obstruction due to mucus or foreign body. C. Hyperventilation causing respiratory alkalosis. D. Decreased venous return due to positive pressure ventilation. Answer: B. Airway obstruction due to mucus or foreign body. Explanation: the most likely cause of a sudden increase in echo and peak airway pressure B is airway obstruction, which can be due to mucus, a foreign body, or an endotracheal tube kink. These obstructions can block airflow and increase resistance, leading to a rise in peak airway pressures and potentially increasing co levels. Pneumothorax could cause similar signs but is less likely to cause an immediate rise in echo in the absence of other symptoms like hypoxia. Hyperventilation C would lead to a decrease in echo, not an increase. Decreased venous return D could cause hypotension but would not directly lead to the changes in echo and airway pressure described. Question 26. A 60-year-old female with a history of congestive heart failure is scheduled for elective surgery under general anesthesia. Which of the following preoperative measures would be most beneficial in optimizing her cardiac function before surgery? A. Administer intravenous furosemide to reduce fluid retention. B. Start a beta blocker to decrease heart rate. C. Increase the dose of her angiotensin-converting enzyme ACE inhibitor. D. Administer an angiotensin-Roman receptor blocker ARB. Answer: A. Administer intravenous furosemide to reduce fluid retention. Explanation: in patients with congestive heart failure, CHF fluid retention can worsen symptoms, especially under anesthesia. Administering intravenous furosemide helps to diurese excess fluid and reduce preload, thus optimizing cardiac function. While beta blockers B are commonly used to manage heart failure, they are not typically administered acutely before surgery unless the patient is stable. Increasing ACE inhibitor C or adding ARB. D. Therapy should be part of long-term management but is not the most urgent preoperative intervention for this patient. Question 27. A 45-year-old male undergoing abdominal surgery under general anesthesia is noted to have a drop in oxygen saturation to 85% after intubation. The endotracheal tube is confirmed to be in the trachea. What is the most likely cause of this oxygen desaturation? A. Pulmonary aspiration. B. Hyperventilation due to insufficient anesthetic depth. C. Right mainstem intubation. D. Increased airway resistance due to bronchospasm. Answer: D. Increased airway resistance due to bronchospasm. Explanation: the most likely cause of oxygen desaturation D after intubation is increased airway resistance due to bronchospasm. This can occur particularly in patients with a history of asthma or reactive airways. Pulmonary aspiration would cause more significant symptoms such as coughing, wheezing, and the need for suctioning. Hyperventilation B would typically cause a gradual drop in oxygen saturation, while right mainstem intubation C would cause localized decreased breath sounds and other clinical signs that would be detected on examination. Question 28. A 32-year-old female undergoing laparotomy under general anesthesia develops a sudden increase in heart rate achieves 130 EPM. Blood pressure equals 160-100 mHg, and signs of autonomic instability. The anesthesiologist suspects intraoperative awareness. Which of the following is the most appropriate next step? A. Increase the dose of anesthetic agents to deepen anesthesia. B. Administer a sedative agent like lorazepam. C. Administer a paralytic agent to prevent movement. D. Initiate emergency protocol for malignant hypothermia. Answer: A. Increase the dose of anesthetic agents to deepen anesthesia. Explanation: intraoperative awareness can lead to autonomic instability, including tachycardia and hypertension. The most appropriate next step is to deepen the anesthesia by increasing the dose of anesthetic agents to achieve an appropriate depth of anesthesia and prevent awareness. Administering lorazepam B is not an immediate treatment for awareness. Paralytic aid C are not useful in the treatment of intraoperative awareness and could worsen the patient's distress. Malignant hypothermia D presents with muscle rigidity, hypothermia, and metabolic acidosis, which is not the case here. Question 29. A 72-year-old male with a history of chronic obstructive pulmonary disease, COPD, and coronary artery disease is scheduled for a cholecystectomy. What is the most appropriate anesthetic strategy for this patient? A. Use regional anesthesia with sedation to avoid respiratory depression. B. Use general anesthesia with a muscle relaxant to facilitate intubation. C. Use regional anesthesia with a high concentration of local anesthetics to ensure analgesia. D. Use general anesthesia with the avoidance of opioids to reduce respiratory depression. Answer: D. Use general anesthesia with the avoidance of opioids to reduce respiratory depression. Explanation: in patients with COPD, D. Minimizing the use of opioids is important to avoid respiratory depression, as these medications can exacerbate the patient's already compromised pulmonary function. General anesthesia with careful monitoring and avoidance of high-dose opioids is the most appropriate choice, while regional anesthesia is beneficial for reducing the risk of respiratory complications. The patient may still require general anesthesia for surgical access and control of pain. Using muscle relaxant B or high concentration of local anesthetics C is not optimal for this patient given his respiratory concerns. Question 30. A 50-year-old male with a history of diabetes and hypertension is undergoing surgery under general anesthesia. After the induction, his blood pressure suddenly drops to 70/45 Hg and his heart rate increases to 120 EM. The patient has a history of anaphylactic reactions. What is the most likely cause of this hypotension? A. Anaphylaxis to a medication or anesthetic agent. B. Hemorrhagic shock due to intraoperative blood loss. C. Neurogenic shock caused by sympathetic blockade. D. Cardiogenic shock due to a myocardial infarction. Answer: A. Anaphylaxis to a medication or anesthetic agent. Explanation: given the patient's history of anaphylactic reactions, the most likely cause of the sudden hypotension and tachycardia is an anaphylactic reaction to a medication or anesthetic agent, such as a muscle relaxant or latex. Anaphylaxis can cause a sudden drop in blood pressure due to vasodilation and increased capillary permeability, leading to hypovolemia. Hemorrhagic shock B would usually be accompanied by signs of blood loss, and neurogenic shock C is unlikely in the absence of a spinal cord injury. Cardiogenic shock D is less likely without additional symptoms of ischemia or arrhythmias.